Welcome to Rare of the Rare. I'm so happy that you could join us as a dive into precision medicine. On behalf of the staff, board, and volunteers at the Immune Deficiency Foundation, we take our mission to serve a community empowered by advocacy, education, and research very seriously. I joined IDF over 30 years ago. My journey with has been extraordinary. My story starts in 1972 when my firstborn son was born with SCID. Dedrick was born a few months prior to the death of my aunt's son, who was later diagnosed with SCID. We were first generation to this disease. So there was no knowledge from family history to tell us what to expect. Dedrick was tested for SCID, and his physicians encouraged us to have him placed inside of the germ-free environment, the same as our beloved David. A few months later, Dedrick passed. He succumbed to pneumonia at the age of 5 months. A few years later, Wesley was born. He too had the deadly disease of SCID. He passed away at 9 months. Our family was devastated. We had no idea that or could believe that this would happen again. Months passed as we wondered about the boys that we'd lost, but we realized that medical technology was not there as of yet. The first bone marrow transplant had been only prior to 1972 when Dedrick was born in 1978. So it was just on the verge of his infancy and learning about SCID. As we moved forward in our life, we had a daughter. She was perfectly healthy, as this was X-linked severe combined immune deficiency. And as you may know, it only affects the boys in the family, and there's a 50% chance of each pregnancy you may have a 50% chance of that child having SCID. Later, a few years later, our son Jerry was born, and yet again, a third son was born with SCID. As Jerry was placed in the hospital due to our history of SCID, he was diagnosed at the age of 2 weeks. He received his bone marrow transplant, and he is living a perfectly healthy life. As of today, he's the oldest living SCID patient in Texas. So what we've learned over the years, and the medical technology has come so far, that we've had the newborn screening. There's so much we've learned over the years. But I joined IDF because I needed support. In 1986, when Jerry was born, there was not a support group. I knew no one else that may have experienced the same medical journey that I was going through. So I reached out to the Immune Deficiency Foundation and found a community that embraced all, that with no questions. And no longer could my son feel that he was isolated or alone, or would I feel isolated or alone. We were embraced into a family with much knowledge and support that our family needed at the time. Living in physical isolation was difficult, but to be trapped in an emotional isolation from feeling that you are the only one was even more difficult. So the Immune Deficiency Foundation filled that void for us. It was amazing to come together and meet, especially for my son, to meet others his age and to know that they understood him. I joined the board, and it's the same efforts of wanting to give back to a community that had been so helpful to me and pulled me through some of the most difficult times in my life. And I have a passion, desire to also, that I would like to share and not other family members to experience the same. Over the course of the next 2 weeks, I think you'll find the abundant amount of information about ultra-rare diagnosis, gene therapy, and clinical trials, all while making connections to others that share a similar experience. It is now my pleasure to introduce our very first presenter, Dr. Joud Hajjar, Assistant Professor of Medicine in the section of Immunology, Allergy, and Rheumatology at Baylor College of Medicine and Texas Children's Hospital. Dr. Hajjar will talk to us about navigating the ultra-rare landscape and relevance of precision medicine. Please welcome Dr. Hajjar.
Good morning, everybody. And Yvette, thank you so much for sharing your story with us. And thank you so much for your introduction. Your story is very inspiring. And honestly, your story describes very eloquently everything and anything that I will be discussing today. And I think the end of this story is the beginning. You know, when Yvette described her son's case and her family's case, it was very, very rare. And then she ends by saying that, you know, we have now the newborn screening. So what once was very rare and very ultra rare is now something that a lot of people know about in the medical field, and as well in the families who are affected, and even in the world of industry and pharmaceutical companies. So this is very important to keep in mind as we look at rare and ultra-rare disease and really try to see the positive outcome and the light at the end of the tunnel. And this is really what I would like to share with you today, my perspective on navigating ultra-rare landscapes. Those are my disclosures. I did receive grant funding from the Immune Deficiency Foundation to advance research in immune deficiency, and I'm so grateful for that. And I have received some funding opportunities as well as some consultations fees from pharmaceutical companies that do provide medications for rare and ultra-rare disease. However, my talk today really does not represent a conflict of interest with any of those disclosures that I provide you today. And what I would like to do is to provide you an overall summary of rare and ultra-rare disease. How are those diseases are defined in the eyes of the legislators, industrial companies, and providers, and kind of walk you through some of the challenges from the provider standpoint of in the diagnosis and the management, but also reflect on some of the achievements that are happening rapidly in the world of ultra-rare disease. So let's start by what is a rare disease. So in 1983, the legislatures and the Congress coined the term Orphan Drug Act to describe diseases that are rare. And in the United States, now we define rare disease since 1983. That is the condition that affects less than 200,000 people within the United States. This definition is specific to the United States. Some other countries will define rare diseases with different terms or different statistics, but this is the definition that applies to us and the legislators and industrial companies when they try to reach a designation for orphan drug. And this is important, and I'll share and explain this a little bit more later on. On average, there are 7,000 rare diseases that we know of, and about 250 novel diseases are described annually. So why this number is not much more? Because some of the diseases, when they were discovered, they were rare. And then we know more and more people who are affected with their diseases that they are no more affecting only 200,000 people, but they no longer become rare disease. You might have heard the term orphan disease, which is a technical term, which means that some of the rare diseases are not very attractive for drug companies to spend the money and invest into finding a drug to treat this orphan disease, because as you can imagine, it's a lengthy and pricey process to develop medications in general. So if there are not a lot of people who will be able to use this medication, then this might not be a very profitable process for drug companies to invest time and money. So they gave the designation orphan disease as a technical term to make everybody aware that there are diseases in which they need to be adopted by drug companies, they need to be invested in, and they have provided some incentives for industrial companies to invest in orphan diseases in order for those diseases to be treated. And I'll go over that in more details as we go through the challenges in management of rare diseases. So what are ultra-rare diseases? There is really no formal definition of ultra-rare disease, but the term was introduced by the National Institute of Health and Care Excellence to identify that there are groups of diseases within the rare diseases that have an indication that might be less than 1 in 50,000 persons. Some of the foundations will define ultra disease as an N of 1, when there is only one case or one family with a proven known disease, or when there is a disease that we only know of 30 people who have the genetic cause of it. So this is an older publication from 2010 that looks at rare diseases in general that are prevalent in less than 200,000 people within the United States. And it tells you that within even those 7,000 rare diseases, the vast majority of the diseases affect 1 in a million or even 1 in 10 million. And if you look at the medical literature that describe rare diseases, very few rare diseases are described in 20 families up to 400 families. However, the vast majority of rare diseases affect only a family or 2 families. So those here that affect really 1 in a million or 1 in 10 million, or really only are described in the literature in 1 family, are what we refer to as ultra-rare disease. If you think about a disease that only affects 1 in or less than 200,000 people within the United States, you would say, okay, this is not very common thing. But if you take all the people that are affected within the United States, you'll end up with 30 million people that are affected in the United States. This is a lot of people. This is the same of number of people who live in our, beloved state of Texas. So although rare diseases are rare in each individual disease, but rare diseases in general affect so many people. And this is very important to appreciate in order for us to say that there is a significance and there is a large need to study those rare diseases and ultra-rare diseases and identify diagnostic methods and treatments for those diseases, because they have a major impact. And if we look at the statistics, we find that children shoulder the largest burden of rare diseases in general. So if you look at all the causes of death in children, you would find that at about 50%, 1 of 2 children who die, whether within the first 1 month of life, the first 1 year of life, or half of the children who die less than the age of 14 have a rare disease. And rare diseases in general take a lot of years lived in the general population. So the term years of life lost means that how many years of life are lost to a specific disease among the general population. And you would find that there are 14,000 years of life lost in the general population to rare diseases. This is 4.2% of all the total years of life lost. This is 4 times more than the years lost to infectious disease and 2 times more than the years lost to diabetes, very common cause of high morbidity and sometimes mortality. And if you look at this figure here on the right, the black line represents the years lost of life in the general population. And as you can imagine, we still have unfortunate uptick of death within the first year of life, because many of the children who are born with severe congenital malformations who which are fatal, may not make it to their first birthday. But in the general population, after that uptake, usually there is a steady state, and usually the vast majority of people go through their life, and we start seeing increase in mortality as the population ages, of course. However, when you look at this gray line, which is the ultra rare and the rare diseases, actually, you see that it does have an impact definitely on children. And it might go down a little bit by the age of 7 or 8, because many of the children who would have fatal rare diseases would have presented a little bit earlier. But however, it does not stop. And we still see multiple upticks during life, even during adulthood and late adulthood. And this is very important. I'm trained as an internist as well as an immunologist and allergist. And it is very important to be aware that we cannot only say that rare diseases, ultra-rare diseases, specifically inborn errors of immunity, affect children or should have presented in childhood. Half of the people that are diagnosed with rare diseases are not children. And this is very important to keep in mind. And, Yvette has very beautifully described her journey with a rare, which was at the time probably an ultra-rare disease. And it really feels like a road untraveled. And for many people with ultra-rare disease, they are actually digging the road themselves, because they might be the N of one. They might be very well the first to travel that road and start that journey for diagnosing their specific ultra-rare disease. However, there are important findings that the research allows us to understand. As we saw, that the children carry the highest burden of rare and ultra-rare disease. And now we know that about 72% of rare diseases are genetically caused. So that means that we have a lead that we can follow that will allow us, hopefully, to identify a population that we should look within very carefully, and then a tool that we can use to help us diagnose and identify the causes for rare and ultra-rare diseases. So if you take a journey for maybe a common disease, a disease that causes symptoms and signs of illness that might affect children that are either very young or just children in general, or affect adults. The disease might be severe enough that put patients in the hospitals or make them seek medical attention from a doctor. Usually the journey starts by the symptoms and sign, a doctor's visit. The doctor will order some blood tests, sometimes some imaging, and if they find something that looks suspicious, usually you'll end up with a biopsy, and the pathologist will look under a microscope, and they kind of have an understanding of what is the disease process. And most of the time in common diseases, they are able to offer treatments that are hopefully curative for the specific illness. However, when this is a rare, or even worse, when it's an ultra-rare disease, this is never a linear pathway. There is a lot of going back and forth. And in general, it takes a really long time, about 6 to 8 years from the onset of symptoms to the diagnosis. Many of our tests are not straightforward, and especially in the world of inborn errors of immunity, we are very fortunate that we have many tests that are clinically available and commercially available for us to test for many of the compartments of the immune system, but none of our tests is perfect. And as the genetic tests are, being advanced, we do have a significant need in identifying functional tests to tell us whether a specific variant is causing the disease or not. Imaging may be very nonspecific, and biopsy results as well are nonspecific. Of course, I mentioned that over 70% of ultra-rare diseases could be caused by genetics. So we can use genetic testing that is now widely available for us to try to understand whether there is a genetic cause of those ultra-rare diseases. And, as you know, we look at the DNA as a source for the most part for the genetic testing, and we read the nucleotides, which are the letters of the DNA. It's really the same concept as reading a book and trying to carefully zoom into the words to look for misspells, which in this case, they are variants, or what we used to call mutations. And we look to understand whether there is a misspell that is causing a change in the meaning of the world, or what we call a pathogenic variant that will lead to change in the protein. And that means that the function of the gene is altered in a way that might be disease causing. So the concept is that we read all those letters and try to understand whether there is a misspell, variant, or mutation that is disease causing. However, we all know that there are barriers that sometimes happen even obtaining genetic testing, although we're very fortunate that now the efforts are increasing more and more to make sure that genetic testings are more accessible. And I think more challenging even that after you do the genetic testing, we might end up with a list of what we call variants of unknown significance, in which we really don't know whether this misspell is really causing a change of the meaning of the world, change in the protein, change in the function of the gene, or not. So there are multiple challenges. Of course, the long journey, lack of experts is another problem, because you have to find experts who are able to recognize the pattern that suggests that there is really a rare or ultra rare disease, in our case an inborn error of immunity, and those could be not very widely available. There are limited confirmatory tests, especially when it comes to confirming that the specific variant is disease causing, especially that many of those variants are newly described to be associated with inborn errors of immunity. Misdiagnosis is a big problem. On an average, the studies suggest that there are about 2 diagnoses that are given wrong for a patient with ultra-rare disease before they get their diagnosis. And the biggest problem is the premature closure, which means that the patient undergoes multiple investigations, nothing is found, and then the journey stops, or prematurely put to a stop because nobody else would like to take this case on and they feel that there is nothing wrong. We lose this case not only for the individual family, which is obviously devastating, but probably for the collective knowledge about this specific rare disease that we're missing. And this obviously causes major challenges to developing therapeutics for rare diseases. When there is a rare disease, we really don't know what's the natural history of it. And when you have a very small number of patients affected with a specific disease, having clinical trials to approve a drug becomes really problematic. As you know, the Food and Drug Administration tries to make sure that all drugs that we are prescribing are safe and effective. This requires preclinical trials, meaning studies that are sometimes done on animals and then done on human in large quantities, sufficient enough to elicit any side effects that might be not found in rare populations before this drug is approved. And this is a very lengthy and expensive process. And at the end of the day, if drug companies think, oh, this is not going to be worth the investment, they may decide not to invest. And that's why the Orphan Drug Act was approved in 1983 to provide incentives for orphan designation, which means that if a company chooses to take on a drug therapy study for a disease that affects less than 1 in 200,000 people, then those companies will get tax credit, they will get waiver of new drug application, which is a major discount, and they will have 7 years of market exclusivity. And this is, of course, very important on a financial standpoint, but there is as well a global and more important scientific gain when we study rare and ultra-rare diseases. Rare and ultra-rare diseases are many times a very pure model, if you will, to study the gene function. And allowing us to study gene function will help us understand the pathway that this gene works through and help us understand multiple biochemical and physiological processes that are not only applicable to this very specific ultra-rare disease, but many times it crossed the roads of other common diseases. And we identify what we call druggable pathways, in which many of the steps in the pathway could be targeted by drugs that could stop the pathway from being overactive or activate that pathway if it was weak because of the genetic mutation. And that will lead us to treatments that are very specific to this ultra-rare disease, but can be very generalizable to many, many common diseases. And the flip of the coin is that when we understand the ultra-rare disease causes or pathophysiology, then we can do what we call repurposing of therapies that already exist. And, you know, because of time, I'm not going to go over all the slide, but the concept is that sometimes the symptoms and the signs of the rare disease are similar to common disease. So we can use drugs that are used for the specific, for many common diseases to treat this ultra-rare disease. Or when we understand the pathway or the gene function that is, you know, having a variant in rare and ultra-rare disease, and we know that this pathway was involved in some common diseases, then we can use the same drugs that we use for common diseases, but share the same pathway with the rare or ultra-rare disease. And of course, there is kind of like the wide genomic approach in which we understand the pathway, we map multiple targets on that pathway, we map multiple drugs and see which one affects. And this is probably going to be the future for discovery of therapeutics for ultra-rare diseases. And finally, although they are rare, ultra-rare and rare diseases and ultra-rare diseases are not forgotten. And the support that is provided nationwide from foundations is very, very crucial for patients, for families, for providers, and even to provide education and significance for the legislatures and therapeutic companies. And I'll put in here very few examples, like the Undiagnosed Disease Network, which is NIH initiative that tries to take on patients who have symptoms suggestive of ultra-rare disease, but they have not been diagnosed through the normal channels of diagnosis, even after seeing experts or doing genetic testing. They are investing heavily in doing more in-depth genetic diagnosis through whole genome sequencing, RNA sequencing, in order to help diagnose those families and provide knowledge that is many times applicable to many other diseases. The Genetic and Rare Diseases Information Center and National Center of Advancing Translational Science are as well important and critical resources that are helpful for patients and family. Of course, the Orphan Drug Act and the National Organization of Rare Diseases. And of course, the Immune Deficiency Foundation that is providing this platform to educate and support patients and families, as well as providers. So I'm over time, but I just want to end up with some reminders that it is a very challenging journey to live or watch a loved one go through ultra-rare disease diagnosis. It is not only frustrating for families and loved ones, but is as well for providers who really thrive to provide answers, but sometimes unable to. There is a diagnosis delay and limited therapeutics. This is a reality that will change because there are bright horizons with the advances in genetic diagnosis and ability to repurpose existing drugs. And I'm sure that you're going to hear beautiful stories about precision medicine repurposing in the coming talks. But we acknowledge that more support is needed on multiple levels in order for us to provide the infrastructure to identify and treat rare and ultra-rare diseases. And with that, I would like to end my talk by thanking the Immune Deficiency Foundation for everything that they do for the patients, the families, the loved one, and support the providers, legislators on multiple levels. Thank you very much for your listening. Have a great day.
And thank you so much to Yvette Shorten and Dr. Hajjar for kicking off our Rare of the Rare Summit this morning. Today's opening session has come to a close. So thank you again, Dr. Hajjar and Yvette, for volunteering your time today.